We have a second thematic session, which is on another topic and again linked on climate justice and health equity. It is entitled Sexual and Reproductive Health and Rights. So this is also linked to our international conference on climate emergency and health. Don't hesitate to listen to the translations. Don't hesitate to send us some Q&A, but you know the system by now, I believe. It will be moderated by Marlies Kazier from Sensoa, Belgium.
Hello, good afternoon, everybody. My name is Marlies Kazier. I'm an international policy advisor for Sensoa, the Flemish Center of Expertise on Sexual Health. I'm also the chair of the Because Health SRHR working group. And I'll be moderating this session, and I have in this virtual space today 3 most interesting speakers that will help us develop our understanding on the interlinkages between SRHR and the climate crisis. First, we'll listen to Kim van Dalen. Kim van Dalen is a PhD student in global public health at the University of Cambridge. Then we will move to Tamari Esho. Tamari has a PhD in biomedical science and in human sexuality studies from the University of Leuven, and she is the director of the Center of Excellence for Female Genital Cutting/Mutilation, AMREF Health Africa. And we'll also have a presentation by Gladys Ngeno. And Gladys is a public health specialist who is currently working with Options as a team leader for the UK funded maternal and newborn improvements, which is shortened for MANI, quality of care project in Kenya. So we'll have first a bigger talk looking at the evidence on the interlinkages between climate migration and SRHR with Kim. And then consequently, we'll go more into a specific country, looking at Kenya, and then specifically at the linkages with FGM in Kenya and the interlinkages between heat and maternal and newborn health, where Gladys will particularly talk to you about solar energy programs that they've developed there. So what I propose to do is that we'll first listen to all 3 speakers, and then we'll try to have substantive time for a Q&A with you. But of course, there's no need to wait with your questions. Feel free to start writing them in the chat, and then the colleagues will pass them on to us. And yeah, so I would be most happy to have Kim take off with her presentation. Thank you.
Hi everyone, thank you so much for being here today. It's a real pleasure to share my work with you. So today I will be talking about a scoping review that we recently conducted on sexual and reproductive health in the context of climate migration. So first, as a bit of background, most of us will likely know that climate change is impacting a variety of different health outcomes. But it is not just heat or just air pollution what we're worried about. What we're really worried about is this kind of multi-hit scenario. Climate change is impacting different health outcomes as well as social mediating factors. And one of these social mediating factors is mass migration. And another thing that we know is that vulnerable and marginalized populations are feeling the health harms most acutely due to climate change. Like with COVID-19, climate change reveals a deeper question of justice, where climate change is interacting with existing social and economic inequalities, exacerbates long-standing trends within and between countries. Therefore, climate change is often called a threat multiplier, intensifying challenges of not only health and its determinants, but also of things as migration, etc. So then to go back to our actual research, we performed a scoping review to assess what is the current evidence on sexual and reproductive health in the context of climate migration. So before starting with our actual work, I want to give my big appreciation to all the team members that are displayed here on our slide. So we have seen that a growing number of people may be forced to migrate due to climate change and climate variability. It is expected that between 25 million and 1 million people are projected to migrate within and across borders by 2050 due to climate change. And 80% of these displaced population are estimated to be women and girls. And worldwide, women and girls face increased climate-induced health risks compared to men and boys. And this is mainly a result of greater exposure and susceptibility due to natural hazards and climate-related damages, as well as less ability to respond to health impacts due to cultural and societal norms. And this includes in terms of dimensions of sexual and reproductive health. For example, the likelihood of adverse pregnancy outcomes is increased by heat waves, new infectious disease patterns may be spread, malnutrition and air pollution resulting from fossil fueling, etc. And likewise, we see that women and girls experience unique SRH challenges during migration. SRHs are often disrupted or limited by migration, which results in high level unmet needs for contraception, unplanned pregnancies, unsafe abortions, but also reduced access to things as antenatal and postnatal care, and more combined stressors of migration processes can contribute to diminished mental health, such as increasing the risk of postnatal depression. Overall, this is seen as a potential risk multiplier effect of compounding vulnerabilities, climate change, and migration. However, currently the literature has not really been exploring what the actual impact of climate migration specifically is on sexual and reproductive health. So therefore, we aim to explore the impact of climate-driven migration on SRH by identifying the current knowledge, identifying knowledge gaps, as well as highlighting potential drivers and factors of SRH challenges in the context of climate migration. So we conducted a scoping review for this that we prospectively registered with the Open Science Framework, and we also used the Prisma adaptation for scoping reviews as a guiding and checklist mechanism. So this guideline is outlined here. You can find it in the supplemental for paper as well, but it is basically outlining how to conduct a scoping review in a systematic way. So methods-wise, when we talk about sexual and reproductive health, we specifically focus on dimensions required for women and girls to achieve SRH, including access to contraception, safe abortion, prevention, screening, diagnosis, treatment of sexually transmitted diseases, as well as pregnancy-related care, including prenatal care, safe delivery, postnatal care, but also things as menstrual hygiene, prevention and detection, and management of gynecological conditions and cancers, etc. And when we talk about climate migration, we specifically on the movement of a person or groups of persons who have to migrate and leave their place of residence either temporarily or permanently due to changes in climate or in the environment. When we look at how we actually conducted a scoping review, we use 6 electronic databases for which we use the search strategy that you can find here. And the full search strategy can again be found in the supplement materials, but we also use Gray literature. And for that, we searched both Open Gray and Google Scholar. And we hand searched a couple of websites of 9 organizations that work on climate migration and SRH as well. And we did forward and backward screening of all included full text and relevant publications. And then we screened through the titles and abstracts by 2 researchers, followed by searching through the full text. And we then extracted the data that was relevant using a predefined data extraction form. And although it is not necessarily needed for a scoping review, we decided to also perform a quality assessment using the Joanna Briggs tool, as well as a checklist specifically made for Gray literature. So when we look here at these 2 figures, this is a flow diagram that shows how we selected the studies that were included. So you see that we started with about 2,800 different studies, and then after duplicates were removed, we screened to 1,600 for the full text, for the title abstract, and then for the full text we screened through 34 different papers, and then eventually we ended up including 10 papers for the synthesis. Unfortunately, because the articles were quite heterogeneous, we weren't able to perform meta-analysis. You can also see here how we performed the quality assessment, so you can find it again in the supplement materials as well. But that is just to show that we overall saw that studies had reasonable quality. But for example, for the qualitative studies, none of them reported adequate approval or reported influence of the researcher on the research itself. And the cross-sectional studies were generally of lower quality, in part due to suboptimal measurements of the exposure outcome, which was often self-reported. And there was a lack of clarity of the identification and inclusion of confounding variables in the cross-section studies. So when we go to the results, we summarize all the results in a table that you can find in our main paper as well. I will not go into too much in depth, but just highlight some of the key findings. So what we found is that in climate migration settings, people were more vulnerable to different forms of sexual and gender-based violence, which included domestic and intimate partner violence, as well as forced marriage and trafficking. And this also all took place, harassment took also place in the relief services itself. And another thing that was mentioned is that there was a reduced access to antenatal and postnatal care, as well as safe delivery, for example. All of this was kind of related to the lack of availability of health services, as well as financial challenges, but also a lack of established relationship with the new community people were migrating to. There were several recommendations made into the different papers for gender-sensitive programming, and the commonly cited recommendations to address SRH needs in the context of climate migrations included developing targeted health systems and services for women's SRH needs, as well as the inclusion and integration of local women in planning of services and education norm change around issues such as gender-based violence. And other recommendations and opportunities that were made were including the economic support for women, gender responsive adaptation and mitigation policies that recognize climate migrants' SRH needs, as well as to improving the referral pathways and resources for gender-based violence. So then, quickly wrapping up, because we only have 1 minute left. A relevant consideration when thinking about the interaction between climate migration and SRH is whether the stressors on SRH are primarily from climate change related factors or migration-induced factors, or whether they are additive in some way or interact in some way. For example, in the broader context of climate migration, the impact of health, food, and water security are important mediators for both mobility, responses, and health outcomes contextualized by climate change. So it's important to take this into what is actually causing this increased SRH risks. In our scoping review, we only were able to study relatively narrow range SRH domains. We also saw that in one specifically in Bangladesh indicated that people that were displaced primarily due to climate change were more vulnerable to diseases than those that were displaced due to other reasons. And this mostly explained due to the inequalities in exposure to poor environmental conditions. So things that we have also seen is that while the majority of the research and or scoping research as well was focusing on the SRH needs of women and girls, this is reflecting the language and emphasis of the literature. It is very important to note that climate migration is also influencing particularly SRH needs of individuals with more diverse gender identities, expressions, and sexual orientations and sex characteristics. For example, gender and sexual minorities are often severely affected by natural disasters due to their frequent marginalization. But there's non-research that we found that was really looking into depth at that. And it's also important to note that there are also specific SRH needs of men that we did not find any literature on that's researching this. Our study has several strengths, including that we had a detailed and comprehensive search strategy and that we included both grey literature as well as peer-reviewed literature. But of course, not all the studies that we included very high methodological quality, and we were not able to include a lot of different studies. And I will now end my presentation because I see I'm slightly overrunning in time. But overall, we see that the scoping review really highlights the need for an increase in the quantity and quality of empirical evidence that is researching the effect of climate migration on SRH. And with that, I would really like to thank you all for listening, and I'm up for questions after my wonderful two other panelists have also shared their presentation. Thank you so much, and thank you again for listening to me and inviting me here today.
Thank you, Malise. Good afternoon, good morning, everyone. And my name is Dr. Tamari Esho. I'm the director for the NFGM Center of Excellence in AMREF. As introduced earlier, I'm here to discuss today the study we did on the intersection between climate change and female genital mutilation, a case of the Maasai in Kajiado County. So Kajiado County is one of the counties in Kenya that is predominantly semi-arid, and it borders Tanzania, so it's in the south of Nairobi. And people that live there are predominantly Maasai, who survive more on livestock rearing and crop farming. So climatic challenges facing the Kajiado people also impacts the agricultural sector. In the last few decades, there's been increase in frequencies of droughts and severity of the droughts, leading to over 90% livestock losses and even 70% livestock losses and 90% crop failures. The Maasai people have low literacy rates and they have high poverty levels. 53% of the population lives below the poverty line. So this study was triggered by an initiative by the county government of Kajiado that was looking for male and female students to be recruited into a TVET training. And this is the training for vocational and educational program in early childhood development. And during that process, they were unable to reach the number of girls that they needed to join. So 95% of the applicants were males, and this identified a gender gap. So in terms of looking for where the girls are, the aspect of climate change came up in the conversations. So our study sought out to look at what are some of the effects of climate change on social and gender norms, and specifically looking at the FGM practice. So we did a qualitative study where we had 12 key informants who took part in the interviews, consisting of administrative chiefs, the heads of households, women and girls, and even county officials from the education department. We also had 8 focus group discussions with the girls. And additionally, we reviewed literature that looked at the issues around climate change. So in terms of the Maasai people, the Maasai have a highly stratified, complex and hierarchical social structure where age and gender serves as the axis of social formation and organization. And role differentiation is very key for the Maasai people. The Maasai's economic activities are based on livelihood or livestock production, that is beef, dairy, hides, and skins. So livestock is really key for the Maasai people. The aspect of climate change impacting the Maasai livelihoods came out when some of the respondents spoke about looking for water for over 10 kilometers and quoting that drought has worsened the water crisis because some of the rivers within the county of Kajiado were drying up because of long durations of drought. The Maasai people also practice female genital mutilation for girls to transition from childhood to womanhood as a transformational process that shapes feminine identity, marriageability, and also legitimizing sexuality. So in terms of the impact of climate change, we find that there's been an increase in annual temperatures over the past few decades. And earlier, in the earlier slides, there was a mention of 0.1% increase in climate temperature rather. And this has led to an increase in frequency of droughts. There's been a lack of water and availability leading to dying animals and vanishing vegetation impacting their livelihoods. And one of the studies mentioned that cattle densities declined with increase in maximum temperature, below 30 degrees Celsius, the cattle density was around 10 animals per kilometer squared. But at 34 degrees, the cattle density reduces to 1 cattle per kilometer squared. So you can see really the impact on the Maasai livelihood. So the participant confirmed that the area had experienced unpredictable rains, periodic droughts, leading to crop failure and lack of pasture and water for their cattle. And hence they're forced to look for pasture in having long distances to travel to forage for in search of forage and water. And some also describe the situation as a tragedy, with rivers and lakes having dried up. Some of the excerpts from our study that I would like to share with you today, coming from a community elder who said that girls are less likely to access formal employment and even to access education because they get married off as a result of the changes in the climatical conditions. And that the girls find themselves crossing the borders into other communities, and these are also other communities, other Maasai communities bordering the Kenya and Tanzania border, and there they stand. Of course, a lot of what the administrative chief mentioned was that the prevalence of FGM had been going down amongst the Maasai people, but climate change is bringing a new threat when families are losing cattle and jeopardizes their livelihoods. One of the mothers-in-law to a new bride that was interviewed also mentioned that the son had to marry a girl because the son had to leave to go and fend for animals for long durations of time, and yet the mother was old. So the son had to marry, to get the son to marry off a girl so that the girl is able to help the woman with household chores. And this is a girl who had dropped out of school. So you can see some of these issues that are coming out from the different people that are showing the increasing risks for women and girls to drop out of school and to get married. And marriage means they have to undergo FGM before they get married. So in terms of the discussion to our study is that we see that climate change has impacted gender inequalities amongst the Maasai and increasing the risks. The lack of seasonal rains and subsequent drought has led to dwindling resources, impacting their livelihoods, increasing poverty levels, like I mentioned earlier. And so the findings reveal that climate change is an emerging threat to the achievement of gender inequality. And this is through socioeconomic disempowerment of women and girls and the persistence of harmful practices that are detrimental to girls and women. So the prevalence of FGM and child marriage amongst the Maasai may be largely perpetuated by the less understood intersections between climate change and widening gender inequalities. So our study proposed an intersectional model of looking at or having interventions that end female genital mutilation, that look at the intersection of climate change, gender norms, and FGM. We propose a bigger mixed method research that looked at the African continent in areas where FGM is being practiced so that we have more rich data on that. So we argue that broader socio-ecological factors pose as barriers to social and gender norms, change amongst the Maasai of Kajiado, and hence the need to adopt a multi-level intersectional approach when designing our programs to end harmful practices. And therefore, we also need to look at strategies that support communities' resilience to climate change, that encourage keeping girls in schools, delaying marriage, and abandoning FGM, that are very crucial to adopt in the face of climate change. Back to you, Marlies. Thank you.
Good morning, good afternoon, and good evening, everyone. My name is Gladys Ngeno. I work for Options in Kenya, and I'm going to be sharing a case of greening the health system from maternal and newborn health outcomes from one county in Kenya in the western side called Bungoma County. And to really put our discussion today to the context of the recent discussions, especially with the end of COP26, we see that the health sector is actually going to receive most of the impact of climate change. And in the last decade or so, we've made a lot of progress in terms of improving global health, but this is actually the biggest risk, and they may undermine those progress we've had in the recent times. And the fact that the health sector also contributes to about 5% to carbon emissions, it means that we must look at ways of reducing our carbon emissions from the health sector. And most importantly, in terms of investment to this sector and looking at what it will cost us by the year 2030, which is quite soon, around 2 to 4 billion per year. And really, no one nation has all this financing to be able to mitigate the impact of climate change. And really, the saddest part is the 250,000 people additional deaths that we'll see every year from malnutrition, diarrhea, heat stress, etc., as spoken by my colleagues. That is the biggest impact we'll see of climate change in health. And as we discussed in COP26, really looking at reducing the temperatures by 1.5 degrees is a global effort. It is not a single country effort. It is all of us looking at every other intervention we need to work on to reduce that. And when we looked at this assessment, we were trying to analyze the nexus between, health and energy. We know that, health, we use energy most of the time to provide services, but then how does that link to affordable energy or clean energy and climate action between SDGs goal number 3, number 7, and number 13 on climate action. And just to bring us into context is just a brief overview about this project. This was a UK aid or now FCDO funded program that was implemented between 2015 to 2018. And the project was addressing, of course, reduction of maternal and perinatal mortality and addressing the key challenges for the 3 delays that cause maternal and perinatal mortality. And there were interventions that are based on community demand creation, but also at the facility, making sure the facility is able to offer quality of care services. So the component that worked on this was on facility upgrade, and the investment from this came from International Climate Fund immediately after the Paris Agreement. So the UK government invested some of its funds to existing programs. So for maternal and newborn health, we know that energy is critical for many processes during prenatal care, resuscitating a child, managing the cold chain for blood, the drugs, vaccines, lab, infection prevention, surgery, etc. There is a lot of energy we use, but then the WHO has given us a formula that when designing, energy requirements, we look at what electricity needs you require, and then that will be used to design the power that you would require. So for this work, the first step we did was to conduct an audit in 60 health facilities that were providing delivery services, meaning conducting deliveries. And some of the key findings from the audit is 75% of the facilities, yes, they were connected to the grid, which is great, but only 3% of that had backup power. And this was using generators. So this means the other 97% of these facilities, services would basically stop when power goes off. And the western side then of the country had erratic supply of power, and the outages would go up to even 3 times a week, lasting up to 6 hours. So it means your mother comes at night, they were not able to get delivery services. And we know that in terms of quality of care, providing also warm water for mothers, especially after delivery, is a good initiative. So based on these findings, we designed a solar systems where we installed them in 33 facilities, and the systems ranged from 1 kilowatt power to 7.5. And these systems also had what we call remote energy management system. So these systems collect the data to show you how much power you've generated today, how is the status of your batteries, the discharge state, how much power generated in a day, and cumulatively for the year, how much has that been? The carbon you've been able to avoid daily and also cumulative during the time of the solar systems working. So this in integrating such technology is also very important to help us collect data and see how much contribution we are doing in terms of reducing the carbon emission. So for the study, we did a cross-sectional study and we only sampled 13 facilities that had energy remote systems. We did a cost-saving estimation and also used carbon emission calculator to calibrate both the energy remote system carbon emissions, but also using the UNEP formula. Then in terms of workload analysis for maternal and newborn health, we used the National Kenya Health Information Systems, where we generated data from that. And then we had key informant interviews for the facility managers and also the clients that visited the health facility. In summary, the outcomes of the installation. Number one was there was improved work environment for the healthcare workers and the client experience. And when I look at this and hear, what the health workers had to talk about is, we all work in corporate offices where we have standby generator, but when a healthcare worker works in a rural facility, they don't have that luxury of choosing to say, I need to work in a facility where there's a generator. Yeah, so having that lighting and be able to actually give services to clients that came to the facility was something that the healthcare workers regarded very well. The other aspect on client experience, there's sometimes when healthcare workers, were not able to provide NC profile services because the lab, maybe there is no power, and the woman will be told, you come back tomorrow or in another day for you to get your NC profile. And that then we lose out on mothers who will be able to screen early for any risk assessment. Secondly, was on improved service delivery. If you look at, I'll just show you quickly on some of the data, immunization coverage. We know we require our fridges to be between 2 and 8 degrees centigrade. So every time a power would go off in a rural facility, it means the healthcare worker has to find a way of, taking the vaccines to a nearest facility where there's a generator for them to still be viable. The other aspect in terms of service delivery is reduce referral of complications. Some of the systems that were installed in these health facilities were able to power incubators. So when you're resuscitating your child, you have everything there, and then you will not be able to refer more. And then generally, and then in terms of the health outcomes, we saw increased stillbirth attendance rate. And of course, this was because of the other program interventions. Together with this, increased first and fourth ANC visits. And then most importantly, there was reduced maternal and perinatal deaths. So just quickly about it, some of the results, we saw that 4% increase in a proportion of fully immunized children between 1 year, a 6-month period between January to June of 2017 and January to June of 2018. The other result that was very impressive was the blood transfusion services. Some of the solar systems, the 7.5 kilowatt, were able to power blood bank fridges and therefore increase the number of facilities providing blood transfusion from 3 to 9. And this is just a quote from one of the healthcare workers saying that they would not start blood transfusion because they are not sure, when power would go off and that pint of blood would spoil. The other aspect is lab services, and this was specifically for antenatal care for the profiling. Yeah. So if you go to a facility today and power goes off, then you wouldn't take your profile test until you have to come back tomorrow. The other services I already mentioned, especially on neonatal care, especially on resuscitation of newborns. This was a big challenge because The sub-county hospitals or the sub-district hospitals, as people know them, did not have backup power. So, and remember this nurse from this facility saying he was actually resuscitating a child and suddenly, power goes off and they lost that child. Yeah. And then on the skilled birth attendance rate, we can also see a big, huge improvement. And this doesn't only mean it's about the solar, but the many other interventions that were done by the program. And then in terms of obstetric case fatality, we saw there was a marked reduction from 2% to 1% in 2017. There was a big strike in Kenya for almost half a year, but you can see the obstetric fatality rate was also improved. And then lastly, on the perinatal deaths, you can see that actually reduced by almost half. And in terms of cost savings, there was savings about 5,000 USD in actually the 6 months we did the study, and about 17,000 kilograms of carbon evaded through this process. So key lessons and the recommendations for this is we look at this as the biggest solution in terms of how the health sector can actually contribute to reduction of climate change impacts. That in praising that the health energy nexus resulted in changes in the health facility where the solar systems were installed. And we can see the positive impact was both on the clients, but also the healthcare workers. So if we merge that together with the climate, that is a very good initiative. Secondly, low maintenance green energy systems are relevant in involving equitable healthcare and augmenting power in remote and hard to reach areas. I know globally we are discussing about universal healthcare, and this actually is a solution that can be able to contribute to that. And lastly, there is really a potential impact for solar energy in reducing maternal and newborn mortality, especially in remote areas. Thank you.
Thank you so much, Gladys. It's wonderful to hear about the life-saving work that you have been doing on this matter, and also very impressed about your resume. If you want to check out all Gladys' experience in working on the interlinkages between health and climate change, checks her biography on the website, because I didn't read all the biographies here of the speakers, but they all have an impressive one. So thank you so much, Gladys. Thank you, Tamari, for getting us understand a bit better the situation of the Maasai in this specific part of Kenya and how they're struggling. Thank you, Kim, for your the presentation of your literature review. We are waiting for questions to come in, but I wanted to kick off with some questions for you as I take advantage of my position here as a moderator. Maybe first to Kim, as you were the first to present. Kim, it's really discouraging to see how little research has been done until now to really look at that impact of climate migration on SRHR. But I was wondering if it has to do maybe with a more general lack of awareness and a good understanding of the SRHR challenges in emergencies, right? Because in emergencies, usually the first thing that is being thought of is access to food, access to shelter. So why should we consider SRHR as essential to the needs of people who are displaced or forced to migrate? Could you take on that question?
Yes, of course. Thank you for that. So I think that ensuring adequate sexual and reproductive health doesn't need to be in opposition to providing food and shelter necessarily. And in fact, ensuring appropriate sexual and reproductive health can support the efforts towards providing food and shelter, because we know that many educated and empowered women and girls can provide most to their communities. And I also don't think that SRH should necessarily exist within a vacuum within migration settings, but be be more a part of a holistic and coordinated mobilizations toward care, and it is both healthcare as other care. But often we see that it is not considered, it's forgotten, or it is overlooked. And when that is the case, we see unplanned pregnancies, we see violence erupting, we see poor birth spacing, maternal and child mortality, and that leads all to compounding vulnerabilities. So yeah, that would be my answer.
Thank you so much. Yeah, that's a very straightforward answer, and I like your stress on having this more holistic approach to SRHR. I had a question for Tamari as well. Tamari, in your presentation, you show this complex interplay between social and economic disintegration and what we consider harmful practices. And I was wondering, what does this imply for development actors working on FGM prevention? So how can they develop programs that go beyond symptom treatment? And maybe you can talk us a little bit or explain us a little bit more about this intersectional approach.
Thanks, Malise, for your question. Yeah, so the intersectional approach that we are proposing is one that looked at all the different areas in terms of surrounding that girl or the woman. What kinds of things are intersecting to impact her life. So in terms of the programs that we are thinking of doing in terms of influencing development programs, the aspect of integrating FGM into the different development programs. So if programs are working around water, sanitation, and hygiene, working around gender inequalities, or education or socioeconomic aspects, these are some of the opportunities for development programs to explore to integrate the aspect of ending harmful practices within these issues. And of course, climate change is becoming more of a bigger problem within Africa and within a lot of our communities that are marginalized and very vulnerable populations. So it's important to really work with programs that are already reaching to those hard to reach populations, so that we have the integration taking place in those areas.
Mm-hmm. Great, thank you so much. And please, in the audience, don't hesitate to take advantage here of the expertise we have in the room and to forward your questions through the chat. Gladys, I have a hypothetical question for you. Given you were hired by our Belgian technical agency, Enable, to assist them in their work because they envision to work much more on climate crisis within partner countries. So say that they would hire you to work more structurally on the matter. What would be the first questions that you would ask them? What kind of questions would you have for them with regards to their take on climate crisis and how it works out in partner countries of Belgium? And those partner countries are mainly situated on the African continent, specifically partner countries in West Africa and then in the Central Africa as well.
Okay, thank you very much, Malise. Yeah, so I imagine that I'm in an interview. Yeah. Anyway, so the first thing that I would discuss with the Enable will be what has really been the impact of climate change, not only in Belgium, but also the countries that you're working in. What's the data showing? We've had a few examples here we've discussed, and most of this really is touching on women and children, about food, etc. So I would request, at least a brief about that. And then secondly, would look at the areas or the countries they are working in, what's their commitment in terms of climate change, and what sectors actually they would like to incorporate aspects of either adaptation, mitigation, or resilience. Yeah, and then would sit down then and look at the strategy in terms of Belgium overseas assistance and how that can be included either in programs for nutrition, for health, for agriculture, etc. So that will be give a very tough questionnaire to the team. Thank you.
Thank you, you're hired. So there's a question from François Saramanan, if I pronounce it correctly, who is actually working for Enable, but it's not to you, Gladys. It's more to Kim. So he was wondering whether unsafe deliveries on the move were not addressed in the review, or if it's due to a lack of information and evidence on the topic, if there's a lack of evidence in the literature that you reviewed. Could you take that, Kim?
Yes, thank you for that question. So we included a very broad definition of sexual and reproductive health, which indeed included unsafe deliveries on the move. But we only found very little literature. And if there was any literature, it would only mention it in 1 or 2 sentences instead of addressing it as this primary question. The literature that we did find on maternal and neonatal health was mostly in relation to access to antenatal care and postnatal care. And there was one study that did mention that there was a higher maternal, child and neonatal mortality rates amongst displaced populations due to climate migration. But that was really what was mentioned in the literature. Of course, there's a lot more literature when we look at migration on a broader aspect and not specifically climate migration. But when we focus on climate migration specifically, we couldn't find any studies that were specifically focusing on that, yeah.
Thank you, Kim. There's another question from François, and this time it is for you, Gladys. Maybe they do want to hire you in Enable. He's saying very interesting SRHR outcomes of your work. He's asking, was the issue of cost or availability of maintenance services also partly addressed in the study or in the work?
Yeah, thank you. Ali, yes, the issue of cost, yes, there's a whole analysis about the cost and how much time would recover, like doing a cost-benefit analysis. And when we did that for the bigger systems, for the 7.5 kilowatts, it's about 8-9 months to recoup actually the capital investment for the solar. And so that is available. I'm happy to share that with the team. And then in terms of maintenance, one thing that we really made sure it's done since the inception of this intervention was to have the government maintenance officers involved in this system design, in terms of siting, in terms of even installation, and the trainings that we did on maintenance. And we did install the solar systems in 2017, and they're still perfectly working to date because they're able to do the routine maintenance. And we also made sure that the batteries that we are providing were maintenance free. Yeah, so it's also very important to look at the specifications of the systems that you're going to buy, especially the batteries, the inverters, and the charge controllers. So we also adapted mostly the UN standards in terms of procurement of those systems. Yeah, thank you.
Thank you, Gladys. And there's another question for you from Nicolette van Duren. She's saying, thank you for the great presentations. She was wondering what other ideas there are to green our health systems beyond solar. And I believe you do have some more experience, right? You've not only been working on solar energy, so I'm sure you can take on that question.
Thank you, Malice. Yeah, so other ideas, I know we've seen globally many companies coming up with rechargeable batteries. Yeah, so you can have an energy backup system where during the day where there is, you have grid power, you charge those batteries and then back them up and use them later. Of course, then these other new technologies that are yet to be really explored, but I believe, in developing countries here, mostly we really look at solar, and I know our government here in Kenya, for example, has built huge solar plants in terms, in efforts to actually move to greener systems of generating power. Thank you.
And there's also a very practical question, Gladys, and then I'll have a question that I'll try to and have the others answer if they can. But what is the average cost for installing a solar system for one health facility? Very practical question. It will probably depend from country to country, but in Kenya, how much would that make?
Yeah, so it depends with the size. As I mentioned, you can install a 0.5 kilowatt, a 1 kilowatt, 7 and 10, whatever system that you would require. But averagely, the cost of a kilowatt is about, I would say around $1,200. Mm-hmm. Yeah, just for 2 batteries and 1 panel and the wiring around $1,200. Yeah.
And that suffices for one health facility?
No, okay. So it's difficult for solar, it's difficult to say it's for a health facility because you have to decide what you want to power. Yeah, you want the system for lighting only, for powering equipment, etc. So you have to do what we call the energy audit and say, okay, for this facility, I want to power the lab, I want to power the pharmacy, or I just want to use it for lighting. So once you get your energy load amount, then you're able to design and say, okay, I need a panels this size, I need battery of this size, and that can, store energy for a certain period of time. Yeah. Mm. Yeah, the normal mathematics won't work here for, yeah, it's actually looking at what is the need that you want to fill in. Yeah.
Yes, of course. Thank you so much for explaining that. Yeah. There was a question to all panelists saying access to SRHR and access to energy at health services may follow the same pattern. How not to reproduce and overcome the barriers for women with disabilities. Is anybody willing to take that on? I don't know, Kim, have you seen anything within the literature, for example, on the intersections of migrants or displaced people, disabilities, and SRHR?
It's a great question. We have not come across anything that's specifically focused on displaced people or migrants that had disabilities. So I would be a bit careful with answering that question myself, but maybe one of the other panelists has an idea.
Tamari?
Yeah, maybe I can just speak with regard to just my experience on the issue. But yeah, so when we're looking at aspects of disability for women and girls, like I mentioned earlier, so being the aspect of inclusion is really important even when designing our programs. And therefore we need to ensure that we increase SRHR access to women living with disabilities and also support them to have increased demand for services. I think integration again plays a significant role because integration will ensure that we take our programs and SRHR services to scale so that we reach the unreached and we also we reach also women with disabilities as a result. Thank you.
Mm-hmm. Thank you. Okay, there's a long remark. Let me see. Thank you very much for the summary of your work. I think it's very pertinent. However, I think that even without climate influences, these reproductive health problems exist and persist in vulnerable countries. In the resources to be provided, we have the dramatic problem of shortages of trained professionals to provide maternal care that still fall short of achieving sustainable development goals. In the context of low-income countries, what kind of balance or attention can be created between the local needs of the country and the migrants, assuming that many of them depend on external aid, and how can this group of people be contemplated in national agendas? A very big question. Kim, do you feel taking this up?
I think this is quite a big question for me to answer again as well. So I'm not completely comfortable, but I can, yeah, I think I may pass it to one of the other panelists if that's okay. Mm-hmm.
But it's maybe too far from your expertise. Huh? But I think, yeah, I mean, none of us would probably disagree with the fact that many of these reproductive health problems do exist also apart from the climate emergency. But let's I think we can easily agree that the climate emergency is aggravating these kind of reproductive health and sexual health challenges or needs. Yeah, when it comes to the integration in agendas, yeah, this is the question of the hosts population and the migrants as guests and their specific needs, but I'm afraid that none of the panelists is really working on this very closely. So I understand if you're not too comfortable with answering that question.
Can I
yeah,
give some,
sure.
Yeah, some insights. I think the question is really insightful. The idea is, how do we create a balance? Yeah. And looking at all the work that we've shared today, we need to create a balance between, the climate, the health, and the social and economic status of the community. And when you discuss about local needs, and for me, I look at local needs as the basic needs in a family. You need food, you need water, etc. Yeah, and that is highly aggravated by the climate change, looking at changing weather patterns, etc. So, that is a big issue. And the aspect of migration from Dr. Thematic, and for me, I mean, we all from Kenya, and we've seen, like, nowadays we see the Maasai is bringing actually their cattle all the way to the city. Yeah, it's because of the issue of climate change. Yeah. And looking at our national agenda and our national climate action plan, the last action plan that ended a few months ago, and I know they're revising a new one, there's a whole concept of integrating issues of climate change to every sector, whether it is in infrastructure, whether it is in health, whether it is in agriculture. And this actually should be the conversation that should be happening in every other country globally on how to integrate climate health, climate change in every department. And it's not only that, but just having that balance of having climate change discussion in every sector of our economy. Thank you.
Thank you, Gladys. I see we have one more question, but I'm afraid we don't have much time left. It's very quickly to Kim. Did you also assess the impact on SRHR of conflicts that may arise during migrants' integration into their new settings, which usually limited access to appropriate healthcare?
Yes, sorry. If I understand correctly, the question is when they are already arrived at their new settings, whatever we also looked at that. Yeah. So we indeed looked again at climate migration of a very broad perspective as well. So both when people are at move as when they are already settled. And a variety of the literature there again also shows that they have less access to, for example, antenatal and postnatal care. And one thing that the literature, especially the qualitative studies, mentioned as well is that it was often difficult for people to access sexual and reproductive health services because they did not have any relationship with the host communities yet, or were not aware of the traditions and the culture there, which made it extra difficult for people to access the services that they needed. And in other cases, the services were simply not available. So that is indeed what was mentioned in the literature as well.
Thank you for your concise answer. So I'm afraid we'll have to wrap up. Thank you so much, all three of you, for these interesting presentations. I feel so much respect for the work that you're doing, so please keep up that good work. And I'm also very inspired as a chair of the SRHR working group to continue to take this team with us in the group and also broader within Because Health as a platform. So most happy to also stay in touch with you and see if there's any potential collaboration in the future. Thank you so much. Wonderful job. Thanks.
That's very well said, Marlies. Much respect for our speakers, Kim van Dalen, Tamari Asho, Gladys Ngeno. And thank you, Marlies, for this wonderful moderation.